All right, we're gonna roll towards you on the number 3. 1, 2, 3.
I'm Dr. Walpert. We're going to be taking care of you today. I know there are a lot of people around you and it's scary, but we work as a big team.
I thought it might have been a little bit heat related, but his tachycardia never came down and stayed sustained.
I suggest we transport him, get some fluids on him hydrated.
What's up, bud?
I'm just dizzy.
Okay.
I don't know why.
All right, you feel like you're going to pass out?
Yeah, I just feel real weak.
Real weak?
Yeah.
Okay, let me get a pulse real quick on you.
If I'm not suspecting trauma, I'm simply going to go to a head tilt chin lift. This presentation will focus on management of sudden cardiac arrest, or SCA, the leading cause of death in athletics. The objectives are to summarize essential information regarding sudden cardiac arrest in your athletes, define emergency preparedness for cardiac arrest at athletic venues, and establish uniform recommendations for the management of sudden cardiac arrest in athletes. Let's start with a case study. March 2006, Vanderbilt University, the day before the SEC basketball men's tournament held in Nashville, Tennessee. The other teams participating in the tournament elected to practice at Gaylord Arena, but Vanderbilt, being the home team in their hometown, had the option of practicing in their gym. This was the day before the tournament started, and they were doing a basic walkthrough practice. A 19-year-old black male basketball player, redshirt freshman, 6'10", 240 pounds. 5 minutes into practice, collapsed during a baseline drill. This athlete had no previous symptoms of palpitations, dizziness, or syncopal episodes. His family history is unremarkable, with no history of sudden death or cardiac anomalies. He was immediately evaluated in the court by the certified athletic trainer and found to be in cardiac arrest. 911 was called. The emergency plan was activated. Someone was dispatched to the training room immediately adjacent to the gymnasium and brought by the trauma bag with their AD. CPR was initiated until the AD arrived. When the AD arrived, it was applied. The time from collapse to the time of analysis was less than 2 minutes. At the time of analysis on the AD, the athlete was found to be in ventricular fibrillation, or VFib. One shock was delivered, and the athlete converted to a perfusing rhythm. This is a strip chart which is downloaded from the AD. You can see here the athlete is in ventricular fibrillation. This gap is a shock, and he converted back at this point to a perfusing rhythm. 2 rescue breaths were administered following the shock, and the athlete began breathing. Oxygen was applied, and he was transported by ambulance to the hospital for further evaluation. An emergency angiogram revealed normal coronary arteries. An echocardiogram revealed hypertrophic cardiomyopathy, or HCM, the most common cause of sudden cardiac arrest in athletics. The athlete was stabilized, and 2 days later an implantable cardiodefibrillator, or ICD, was implanted. He was disqualified from further intercollegiate athletics. However, he continues today to remain in good health. This next case study happened at the University of Georgia in May of 2011 on the first day of the SEC Outdoor Track and Field Championships. A 60-year-old track and field coach from Mississippi State University, standing in the infield during the last race of the 400-meter decathlon. This coach had a history of a prior coronary artery bypass surgery 11 years before. Suddenly collapsed in the track infield. Was evaluated, found to be unconscious, unresponsive, and in cardiac arrest. CPR was started immediately within 30 seconds of the time of collapse. An automated external defibrillator was located in the track and field medical stands approximately 50 yards away from the site. Help was immediately dispatched. 911 was called. The emergency action plan was activated. The AD was retrieved. Approximately 1 minute elapsed from the time of the collapse until the time of analysis and the first shock with the AD. He was successfully resuscitated on the field. He subsequently arrested again and was shocked a second time, and again was successfully resuscitated. Ambulance arrived. He was transported to the hospital. He had emergency cardiac catheterization. Surgery the next day was performed to place an implantable defibrillator and pacemaker in, and subsequently had a redo CABG surgery and is doing fine. These are two examples of the importance of having an emergency action plan, prompt recognition of sudden cardiac arrest, prompt CPR, prompt AED usage. Sudden cardiac arrest is again the leading cause of death in young athletes. And it's sustained by over 300,000 people annually in the United States. Surprisingly, despite having one of the finest healthcare systems in the world, in the United States today, approximately 95% of all sudden cardiac arrest victims die before reaching the hospital. The tragedy is healthy appearing competitive athletes may harbor an unsuspected cardiovascular disease with the potential to cause death. This is scenes from a high-profile death last year. 16-year-old Wes Leonard, who collapsed on the basketball court and later died after scoring the game-winning shot in overtime, helping his team clinch a perfect season. The cause of death was hypertrophic cardiac arrest due to hypertrophic cardiomyopathy. What is sudden cardiac arrest? SCA is electrical disruption of the heart's natural rhythm in which the heart stops beating altogether. This is not the same thing as a heart attack, in which one or more of the heart's main blood vessel becomes blocked, preventing blood from reaching the heart. Most often, sudden cardiac arrest strikes suddenly and without warning, causing victims to collapse and become unconscious, whereas heart attack patients typically experience chest pain and remain conscious. Again, your typical heart attack patient may complain of prodromal warning signs: crushing substernal chest pain, difficulty breathing, shortness of breath, nausea, vomiting, diaphoresis or heavy sweating, radiating pain at the neck, the jaw, the left arm, where typically the most common sign of sudden cardiac arrest is death. Athletes usually display no symptoms prior to the event, and unfortunately few athletes are identified at risk prior to the episode. The deaths are usually associated with intense physical activity. This is a picture of Ryan Shea, a world-class marathoner for the U.S. track and field team, who died 5.5 miles into the 2008 U.S. Olympic Team Trials Marathon in 2007. Athletes are generally considered to be the healthiest members of society. When we have an unexpected death in training or competition in a young athlete, it's considered to be a catastrophic event, and many implications occur. When we have an unexpected death in an athlete, it stimulates debate about their pre-participation physical exam. What was it composed of? Did it have a cardiac component? Was there an emergency action plan? What type of emergency care was rendered? Who were people present there? Did they know first aid? Did they know CPR? Did they have the appropriate equipment available on site, or it could be recovered in a timely fashion? The first reported case of athletic cardiac arrest actually happened 490 years before Christ in a Greek athlete and soldier named Phidippides. Phidippides was a Greek soldier and actually an Olympic champion. The Greeks had just had a great victory against the Persian army. And this was 490 years before the birth of Christ. They didn't have radios or cell phones or telephones, so they had to find a way to deliver the message to the king. So they used runners. Phidippides was a great athlete, was selected as a runner to be able to take the news of this victory to the king. He ran 26.2 miles from the city of Marathon to Athens, delivered the message to the king, and collapsed and died at his feet. And from this story is where the name Marathon comes from, and the distance at 26.2 miles. The first reported case of athletic cardiac arrest. These are the faces of cardiac arrest today. It's non-discriminatory. It happens in males, in females, black, white, Asian, football, basketball, swimming, wrestling, volleyball, hockey, lacrosse. It can happen anywhere, at any time. Not only can it happen to athletes, it can also happen to coaches, officials, and spectators. As athletic healthcare providers on the scene of care, we may be responsible for others in addition to our student athletes. And if you think about it, many of these individuals may have significantly more risk factors than our athletes themselves. What's the etiology of sudden cardiac death in athletes? Now, typically when we have an older person have cardiac arrest, it's caused from a heart attack, atherosclerosis, where they have plaque or blockage in the coronary arteries. Typically with an athlete death, it's a congenital problem. It's usually a structural cardiac anomaly. The most common one occurs about 25% of the time, is hypertrophic cardiomyopathy, or a thickening or an overgrowth in the wall of the left ventricle. HCM, the most common cause of death, sudden cardiac arrest. Another common cause is a coronary artery anomaly, about 14% of the time. The second leading cause of cardiac arrest is actually a situation where there's absolutely nothing wrong with the heart. It's a situation called commotio cordis. It's caused by blunt, non-penetrating blow to the chest, which induces a fatal arrhythmia in an otherwise structurally normal heart. Approximately 20% of all sudden cardiac arrest in athletes is caused by commotio cordis. This is a picture of George Moriarty, a great lacrosse player who died of cardiac arrest from commotio cordis while competing in a game on the Cornell field. Playing defense, he jumped in front of the goal to block a shot, received a hard strike to his chest, took a couple of steps, stumbled, fell down face down, collapsed, unresponsive, and died on the field of cardiac arrest in front of his teammates. Commotio cordis has been studied by Mark Link, an electrophysiologist at Tufts University. The key thing is the timing of the blow. If the athlete receives a blow in the silhouette of the heart, right at the upstroke of the T wave, there's a 90% or better chance that will go into sudden cardiac arrest. This is a picture of Hayden Walden, a 13-year-old Little League player in Phoenix, Arizona, who died in 2011 from commotio cordis after being struck in the chest by a pitch ball while attempting to bunt. He took an inside pitch right in the chest, a legal official said. After that, he took 2 steps to first base and collapsed. This is a picture of a 16-year-old lacrosse player from Syracuse, New York, who also collapsed from sudden cardiac arrest, commotio cordis last year, was struck in the chest with a ball, but fortunately he had immediate care from a certified athletic trainer on the field who promptly recognized his signs and symptoms, initiated CPR, retrieved the defibrillator, and shocked him and brought him back to life. From an etiology standpoint, there's a variety of other cardiac structural anomalies. Myocarditis, ARVD, Marfan syndrome, and others that can cause death. In about 2% of sudden cardiac deaths in athletes, the postmortem exam fails to identify any structural cause of death. Other factors to consider: recreational drug use. Many of us remember the tragic case of Len Bias, a first-round draft pick from the University of Maryland for the Boston Celtics, who that night after the draft ingested cocaine for the first time and died of sudden cardiac arrest. There's a high correlation of cardiac arrest with cocaine use. Performance-enhancing drugs or nutritional supplements, such as Steve Beckler, the pitcher for the Baltimore Orioles, who died during training camp after ingesting ephedra and exercising. Or an underlying medical condition such as sickle cell trait, which manifests in rhabdomyolysis and ultimately a fatal cardiac arrhythmia. What's the incidence of sudden cardiac arrest? Barry Maron, a cardiologist from the Mayo Clinic in Minnesota, estimates approximately 110 athletic deaths per year from cardiac arrest. Basically, every 3 days, a young competitive athlete suffers SCA. The problem that we have right now is there's no national surveillance system. So actually the true incidence is really unknown and most likely underestimated. The reality is this 110 death projection may be the tip of the iceberg. In a study conducted by Dresner and Harmon at the University of Washington in 2011, looking at the incidence of cardiac arrest in college athletes is determined to be 1 in 44,000. Let's look at the pathophysiology of cardiac arrest. What happens when the heart stops? First is the electrical phase. Less than 4 minutes following arrest, the cardiac muscle uses up its sugar and its oxygen stores. Next is the circulatory phase. From 4 to 10 minutes following the arrest, the cardiac muscle switches to an anaerobic metabolism. Last is the metabolic phase. Greater than 10 minutes following the arrest, the cardiac cells swell, rupture, and die. John Dresner, a team physician at the University of Washington, published an article on heart rhythm in July of 2006. In 2005, the NCAA had 9 documented cases of sudden cardiac arrest in intercollegiate athletes. 8 of these athletes died. John did a retrospective study trying to reconstruct the chain of events, interviewing athletic trainers, emergency medical technicians, physicians, reviewing autopsy reports, and look at the timing and the details of resuscitating these 9 young athletes. All of the athletes had a witness collapse. The average age of these 9 athletes was 21 years old. CPR was begun within 30 seconds, 6 of the cases, and by 1 minute, 2 additional. The AED was provided by athlete trainer in 5 cases and by EMS in 4. It was found that the average time from arrest to defibrillation was significantly decreased if the ATC brought the AED as opposed to EMS, 1.6 to 5.2 minutes. Despite these response times, which seemed to be very appropriate, 8 of these 9 athletes died. Cause of death, 5 HCM, 2 commotio cordis, 1 a hockey player, 1 a lacrosse player struck by a ball or a puck in the chest, 1 by myocardial infarction. Interestingly, the only person who survived showed no structural heart disease, and it was never determined the precise cause of the cardiac arrest. So the bottom line, despite witness arrest in 9 athletes, immediate CPR, prompt AD use, we had a limited success, and survival is much lower than expected in a small population. What can we make of this? Based upon this, the National Athletic Trainers Association convened an inter-association task force trying to look at commonalities. Now, many healthcare organizations have had guidelines for managing SCA, but they never directly linked emergency planning and SCA management. 15 different national organizations with special interest in SCA were involved in this task force. Inter-Association Task Force came out with a consensus statement and an article which is published in 4 different journals: Sports Medicine, Heart Rhythm, the Journal of Athletic Training, and Pre-Hospital Emergency Care. The job was to summarize essential elements of cardiac arrest in young athletes and to outline necessary elements for emergency preparedness and a standardized treatment protocol. The first part of management begins with emergency preparedness, encompassing an emergency action plan, making sure that everyone involved in athletics, not just sports medicine staff, but coaches and strength conditioning staff, know first aid and AD training and CPR. Having access to early defibrillation by having an AD on site. Every athletic organization have an emergency action plan. It should be reviewed and practiced regularly, at least once a year. Identify targeted responders and train them in CPR and first aid. Again, not just your sports medicine staff, but coaches and strength conditioning staff. The most critical component is access to early defibrillation, and we want to have a target goal of less than 3 to 5 minutes from the time of collapse to the time of the first shock. Again, the EAP should be reviewed at least annually, and someone needs to be in charge of reviewing equipment and making sure it's ready. The next step is recognition. We can't treat emergency effectively if we don't recognize it. I recently attended an NCAA summit in Colorado Springs looking at the incidence of death in strength and conditioning. In Division I football in the last 10 years, we've had 21 documented cases of sudden death in athletics. In Division I football in the last 10 years in the actual sport, we've had 0 deaths. So in strength and conditioning from January 1 to the end of the season to the start of two-a-days, we've had 21 deaths with athletes in 10 years. When we looked at these 21 deaths and looked for commonalities, one of the things that we saw in virtually every one of these deaths, medical staff were present. Athletic trainers, physicians, or emergency medical technicians. But many times there was delay in recognizing the emergency himself. So we need to have improvement in the recognition of sudden cardiac arrest. What are some barriers? Inaccurate assessment of pulse or respiration. In some of these cases, 1 or 2 or 3 minutes elapsed while the athlete had no pulse before it's recognized the athlete was in cardiac arrest, and 911 was called and CPR was implemented. The presence of agonal or occasional gasping. This is not normal respiration. And lastly, sentinel seizure, myoclonic or seizure-like activity. Approximately 50% of the time in a witnessed cardiac arrest, the athlete will demonstrate sentinel seizure. This is a video of Hank Gathers at the time of his death. He makes a basket. He starts to go up to play defense. Watch the next few seconds. He seems fine, and suddenly he collapses. Watch his arm and leg activity. This is a classic sentinel seizure. This is not a true seizure, but simply myoclonic muscle activity. And again, this happens about 50% of the time in a witnessed cardiac arrest. Now watch closely again at the leg and arm activity now. What have we always taught in the past with seizure activity? Leave it alone. It'll subside in a few seconds and they'll be okay. If we have an athlete who suddenly collapses and exhibits seizure activity, our first thought should be cardiac arrest. Check for airway, breathing, circulation. Unfortunately, he died on the court. We should have a high suspicion of cardiac arrest for any collapsed and unresponsive athlete. Recognition of SCA also involves commotio cordis, the second leading cause of cardiac arrest, approximately 20% of the cases in young athletes. If we have a young athlete who's struck in the chest by a projectile or by contact with another player, he should be suspected of having cardiac arrest from commotio cordis until he's clearly responsive. This is a Taekwondo tournament. Watch the athlete on the left. He takes a blow to the chest. Doesn't seem that dramatic a blow. Goes to the line, collapses. The referee calls for medical help. The athlete was hit with the chest. It's chest contusion. They open up his uniform, assess his chest. Unfortunately, no one assessed his airway, his breathing, or circulation. This athlete died on the mat of commotio cordis. 14 years old. Tragically, this video was filmed by his mother in the stands. If we ever have an athlete struck in the chest who collapses suddenly, we will always think about cardiac arrest from commotio cordis and rule that out first. Let's talk about the chain of survival, which the American Heart Association talks about. The concept of chain is only strong as the weakest link. We have 5 separate components. The first thing is recognizing the fact that cardiac arrest exists. We can't treat it if we don't recognize it. So recognition, activate the 911 call, activating the emergency action plan, starting CPR with emphasis on chest compressions, rapid defibrillation, hopefully having this AD on the scene so we can minimize response time, advanced cardiac life support, and then integrated post-cardiac arrest care in the hospital. This is a heart in defibrillation. The greatest single impact on survival statistics is rapid defibrillation. Many people have a misconception about what actually happens when the AED is administered. A shock is not administered to start the heart back. A shock is administered to stop the heart. The heart is in ventricular fibrillation. It's quivering in a chaotic fashion. It's not an organized sequence with blood pumping and flow. What we want to try to do is do a strong electric current across the heart to stop the heart, similar to when a computer freezes and we have a cold boot. Your computer freezes, you hit Alt Control Delete, or you turn the power switch on and off. The computer turns off, it turns back on, and hopefully an internal organizing system causes the computer to boot up again and function in normal fashion. That's exactly what we do when we defibrillate the heart. We stop the heart for approximately 5 to 10 seconds, and hopefully the internal pacemaker and the sinoatrial node will reorganize normal electrical activity and reboot the heart. But basically when we're doing an AED, we're doing a cold boot of the heart. Again, the most common cardiac arrhythmia with sudden cardiac arrest is ventricular fibrillation, or VFib. We have an abnormal, irregular, very fast heart rhythm. The heart cannot pump blood effectively. The victim is unconscious, they're not breathing, there's no sign of circulation. The only definitive treatment to correct this is defibrillation. We cannot correct this with CPR. We're strictly buying time and trying to ensure adequate circulation until such time as we can't shock the heart. The major determinant for survival is time to defibrillation. In a classic study published in the Annals of Emergency Medicine, it was determined the survival rate decreases approximately 10% each minute from arrest. CPR should be implemented while waiting for an AED. As soon as the AED arrives, CPR should be stopped, the AED applied, and turned off for rhythm analysis. The chance of survival decrease with time. CPR also plays a critical role. In this study here, looking at the combination of CPR and AED, these are survival rates where CPR started in 1 minute and then defibrillation. CPR started at 5 minutes with defibrillation. CPR started at 10 minutes with defibrillation. And CPR 15 minutes with defibrillation. Again, the concept of CPR is buying time, trying to get adequate circulation until such time as we can't shock the heart with a defibrillator. The new 2010 HA guidelines, CPR is easy as CAB, circulation, airway, breathing. Circulation starts with compression, so we have an emphasis on chest compressions. We want to push hard and fast on the center of the victim's chest, a rate of 100 a minute, a depth of compression of 1.5 to 2 inches. Compressions first, 30 to 2. After 30 compressions, then open the airway. Tilt the victim's head back, head tilt, chin lift. Breathing. 2 breaths, immediately go back to compressions again. This is a new algorithm. Unresponsive, not breathing. Activate 911. Start CPR. Get a defibrillator. CPR, 2 minutes, shock. CPR, 2 minutes, shock. Push hard and fast, trying to minimize interruptions in chest compression. As soon as the shock is delivered, immediately go back and start compressions again. Don't stop until there's signs of life. In the second case we had here at the SC Track and Field meet is a great example. We administered the second shock. I immediately started chest compressions. 28, 29, 30, as I was preparing to breathe, the victim actually reached up and grabbed my forearm to stop compressions. That's a sign of life. But sometimes it takes a while for the heart to actually re-trigger once we start a normal rhythm. So as soon as we administer that shock, we immediately go back to chest compressions, and we do not stop until we have viable signs of life. What's the effectiveness of CPR? CPR has been shown to extend the ability of the heart to survive for longer times than fibrillation. But we cannot start a normal heart rhythm with CPR alone. Best case with good CPR performed at a rate of 100 compressions a minute and a normal depth of 1.5 to 2 inches, we're going to get about 30 to 40% normal stroke volume. Again, we're simply trying to buy time. The new HA guidelines 2010, we want to push hard and fast, a rate of at least 100 compressions per minute. We want to make sure we allow full chest recoil. This is a very common problem, particularly in males. As we get tired, we tend to lay on the chest with our weight, and we're not pushing the heart down. Again, we're thinking about the concept, the heart is a pump. We have a bony prominence on one side with our vertebral column. The heart is a pump, and our sternum, we're pressing back and forth, up and down. We want to make sure we get full chest recoil, so we're doing this and not that. 32 compression to breath ratio. If the downtime is unknown or greater than 4 to 5 minutes, we want to start first with CPR, initiate some circulation before the use of the AD. If the downtime is less than 4 to 5 minutes, immediately go to the AD. We want to minimize interruptions in CPR, stop CPR only for rhythm analysis and shock. Resume CPR immediately after shock, beginning with chest compressions, repeat rhythm analysis every 2 minutes or 5 cycles of CPR. Other thing to think about is compression sufficiency and rescuer fatigue. If we have 2 rescuers, every 2 minutes we want to change the chest compressor to ensure high quality CPR compressions. The AD will analyze the rhythm. It has an algorithm within the unit. It will advise shock or no shock. We have 2 shockable rhythms, ventricular fibrillation and rapid VT. On occasion, you may have a non-shockable rhythm. You may have an athlete in a rest and the AD advises no shock. This is typically asystole or P, pulseless electric activity. In this situation, continue CPR and realigns again every 2 minutes. AD program implementation, we must have a medical director and a prescription to purchase a unit. We need to have an emergency response plan. It needs to be filed in conjunction with your local EMS agency. And we need to give care about where we're going to deploy our ADs to have the quickest response time. They need to be in an area where there's quick access. There's been several tragedies in recent years where there's been a death reported and there was an AD on site at the high school or the clinic or the facility, but unfortunately it was locked inside an office and no one can access it. So make sure the ADs are deployed in such a manner where they can be rapidly retrieved. NATA official statement on ADs. An AD should be part of an athlete trainer's emergency action plan. The Heart Association recommendation for school facilities. AD should be on site with a target response of less than 5 minutes. The 36th Bethesda Conference. AD should be available at educational facilities. Devices should be deployed to provide a response time of less than 5 minutes. In the recent 2010 guidelines, 2 other recommendations were the possible use of automated chest compression devices. This is an example of a mechanical piston device. These are not mainstream right now, primarily because of the cost. This device currently costs about $16,000, and it may not be feasible to be on all ambulance units. This is an example of a low distributing band CPR device. The advantage of these is in a long response, particularly in a rural setting, where there may be a 25 or 30-minute transport. It may not be feasible for the rescuer to deliver CPR high quality for this amount of time. This, we can be consistent with 100 compressions a minute and make sure we're getting the right depth. This is a device called an impedance threshold device, or rescue pod, also recommended for use in the 2010 AHA guidelines. One of the problems that we typically see in sustained CPR is gastric distension with air going into the belly. And what happens, the more air into the belly, eventually we may have the athlete vomit, which can also complicate and cause airway problems. What the impedance threshold device does is prevent unnecessary air from entering the chest during CPR. It makes it more efficient with more blood flow to the heart and the brain. Another thing recommended in the 2010 HA guidelines is the use of therapeutic hyperthermia after cardiac arrest. We've had higher success rates with cardiac arrest with such cooling activities. 12-lead echocardiogram in the field. This is another example of the case that we had at the SEC Track and Field Championships. We had 12-lead EKG capability in the field. We actually did an ECG on the track and field coach in the ambulance. It was transmitted by fax to the hospital. The cardiologist was notified. The cath lab was cleared. So when we arrived at the hospital, he was immediately taken up for cath. This reduction in cath times with early notification can make a significant difference in outcomes. Prevention. What is our role right now? What's the role of cardiovascular screening? Now, right now, pre-participation screening is widely practiced, but there's not a lot of universal agreement. There's many complex factors here regarding feasibility, cost effectiveness, and false positive results. want to close with this picture. I have 4 children, and this is my middle son, Luke. At this time, he's 4 years old and just had open heart surgery. I was at football practice a few years ago, and my wife called and said, you know, we've got a problem here with the cardiologist, and Luke needs open heart surgery, and needs it now. 24 hours later, I'm at Children's Hospital in Atlanta, Georgia, meeting with a cardiac thoracic surgeon. And I'm sitting here looking at papers and talking about surgery success rates and mortality rates and morbidity rates, which is pretty sobering when we're talking about your 4-year-old son. And I always remember in the middle of this, he stopped, he said, Ron, I've gone over a lot of statistics, but the only number you really care about right now is number 1, and that's your son. And he's exactly right. You know, we can talk about statistics all day on survival rates and use of ADs, but the bottom line, when we have an athlete in cardiac arrest, and we're doing CPR on the athlete, pumping on their chest, the only number we care about is number 1 in saving the athlete's life. So I encourage you today to go back and assess your readiness plan for cardiac arrest. You know, what are your capabilities from an equipment standpoint and from a training standpoint? Do you have an adequate emergency action plan? Have you rehearsed it within the last year, not only with your sportsman staff, but all of your athlete teams and coaches? Do your coaches know first aid and CPR? If a situation happens with cardiac arrest today, are you prepared to handle it? Thank you.